So, Michael, tell me about the toxicities of the adjuvant treatment. I mean, it did seem like there were differences. It did seem like the proportion of patients who had to stop from toxicity did appear to be different between PD-1 trials and dab-trem. Is there a threshold or is there an issue with you treating a really low-risk 3A in terms of toxicity? Does that play into your decision-making?
This is always a risk and benefit decision that you have with the patient. So if their risk is lower in general, then if they're having toxicity, I'm more likely to discontinue them early because I can't say that we need this treatment that badly because I'm not sure what that relative benefit of ongoing treatment is in that case. So if I have a really high-risk stage 3C patient that's on adjuvant treatment with some mild or moderate toxicity, I might be more inclined to try to get them through the toxicity and continue treatment longer. If it's really early risk, stage 3A, and I was on the fence about even treating them at all, and they're having very mild to moderate toxicity, that's a patient I might be more inclined to discontinue early. So I think that it's a threshold that you have with each individual patient about how much you really feel that they need that benefit from adjuvant treatment, and then what their side effects are. And there's totally different side effects with the dabrafenib and trametinib versus the immune therapy, and I think that's also a really important issue to talk to patients about, because in the adjuvant setting, we have to think about toxicities differently than we do in the metastatic setting. Many of these patients are cured with surgery alone. We know there's a high risk, and of course, that's why we're even thinking about adjuvant therapy. But these are patients that are not sick with cancer. They've had all their cancer resected, and so they're healthy people that are getting treatment that might be making them sick, and so you really need to try to understand what their experiences of the toxicities are and how it's affecting their quality of life. And
do you think the toxicities differ in the adjuvant mode versus the metastatic mode?
There's always a notion that there's greater toxicities, at least with immune therapy, that's been discussed in the adjuvant setting, and perhaps is that because there's less tumor burden that's around that's otherwise in creating some immunosuppressive environment that mitigates toxicities in the metastatic setting. So I think there may be this sense of higher toxicities with some immune therapy combinations, particularly in the adjuvant setting. I don't think it's totally clear yet exactly which one is better or worse. I think one thing that we do know is the toxicities are generally similar in terms of the kinds of side effects you have in the metastatic setting versus the adjuvant setting, but there might be more long-term implications in the adjuvant setting. So if you have young patients that have a new endocrinopathy with PD-1 monotherapy, now for the rest of their life, they'll be hypothyroid or have secondary adrenal insufficiency. That may have different implications 20 or 30 years down the line than a patient with metastatic disease may have, or at least that we know about right now. And that's an important thing to think about because of the permanency of some of these immune therapy side effects.
So Hussein?
I would actually definitely agree with you with the fact that in the adjuvant setting, we really have to have a much lower threshold for stopping for toxicity and actually to really think about what the impact for those patients that are otherwise surgically cured in terms of what are the long-lasting toxicity. And that's actually one of the reasons that the discussion around PD-1 versus BRAF is really important because and with BRAF targeted therapy for BRAF mutant patients, the toxicity rate appears to be higher, and patients are, develop fevers. And to your point, there's observations, especially actually in the neoadjuvant setting, that the toxicity rate seems to be higher in patients that don't have active disease compared to the metastatic patients, which may have a more immune suppressed, kind of system. So in those patients with dabrafenib, trametinib, for instance, the toxicity is a higher rate, but you stop the pills, the toxicity goes away, and the patients can move on with their life. With anti-PD-1, the rate of toxicity is a lot lower, but there is definite concern that some of the toxicities are long-lasting. And I think with every patient that we discuss adjuvant therapy, the endocrinopathy part is very important. Especially for melanoma, we have some patient population that are really young. Even fertility is an issue in young females and even in young males, patients that are going to live for the rest of their lives with potential outcomes from the adjuvant therapy. So I think it's very important to discuss those issues with those patients and make the decision, have a much lower threshold to stop, and again, make sure that the patient agrees with proceeding with therapy. But in general, from the 3A perspective, I know you guys were discussing, can you extrapolate the data from the 3B, 3C, and M1A to 3A patients? I really think that the hazard ratios are impressive enough that it's not much of a stretch to say that the biology seems pretty consistent across all of these subgroups, and patients are expected to respond to a similar manner in each of those.
And I guess, Hussein, to add to that also, from me from a surgical perspective as well, sort of this is a discussion that I have initially with the patients when they come in before we involve our medical oncologists, because they now had a positive sentinel lymph node and they are a 3A patient. And I think that we know that at least with the targeted therapy, with the dabrafenib and trametinib, that if we then look at that, kind of reanalyze this according to the 8th edition, that we have the true new 3A patients, that the hazard ratio is maintained there. So I think that that is quite impressive. I think that we have to recognize, though, that even in those 3A patients that were part of these studies, they still had a fair amount of tumor. There's a 1 millimeter tumor that they had to have in that sentinel lymph node. And I think that overall in the United States, they actually represent the minority of patients. The majority of patients that we see in the United States right now actually have less disease in their sentinel lymph node than that. And I think that we haven't really studied that, so we don't really know the true impact in those patients. So I think that there's still more things that we need to do.